My name is Masataka Yoshinaga, and I'm a cardiologist at Fujita Health University Banten Hospital in Nagoya, Japan. Thank you very much for joining to how-to video. In this presentation, I will demonstrate our technique for minimalized radiation exposure during chronic total occlusion percutaneous coronary intervention by using the novel SPOT ROI function. I hope this video will provide helpful tips and practice insights, especially for those interested in advanced CTO PCI procedure and radiation safety. Let's get started. Today, I will present our recent experience entitled Using the New Spot ROI function in Chronic Total Occlusion Percutaneous Coronary Intervention to archive successful outcome with low radiation exposure. In this video, I will show how we successfully use the spot ROI function, a novel technology for reducing radiation dose in a complex CTO PCI procedure. I hope you will find this presentation informative and helpful for your practice. Thank you. COI disclosure. I'd like to briefly review the current challenges associated with radiation exposure during CTO PCI. Furthermore, the current global CTO-PC algorithm published in JACC 2021 recommends considering termination of the procedure if the radiation dose exceeds 5 gray. As reported in a contemporary multi-center registry published Canadian Journal of Cardiology, 1/3 of patients undergoing CTO-PC are exposed to a high radiation dose exceeding 4.8 gray. Male sex, high BMI, hyperlipidemia, history of CABZ, moderate or severe calcification, vessel toxicity, ambitious proximal cap, distal cap bifurcation, longer CTO occlusion lengths, and blunt or non-blunt stumps were all associated with higher patient air kilometers. Here we have examples demonstrating a typical radiation exposure and procedure time in complex CTO cases. For a patient with a BMI of 29.6, male sex, high BMI and moderate or severe calcification, vessel toxicity, distal cap bifurcation, longer CTO occlusion lengths, and the presence blunt or no blunt stumps, the factors that are expected to be associated with higher air kilometers, resulted in a total air kilometer of approximately 4.1 gray, with a procedure time of 200 minutes. Given these realities, common clinical question areas, I want to perform complex PCI without having to worry about radiation exposure. Is there any effective way to archive that? In this presentation, I aim to answer that exact question. The Canon Alpha Evolve Edition is a state-of-the-art angiography system designed to meet the advanced needs to interventional cardiology and radiology. This cutting-edge platform provides outside image and quality and flexible system configuration. Innovative dose reduction technologies to support complex procedure with safety and precision. Deliver high AI resolution images and advanced imaging algorithms, allowing for precise visualization of vascular structures and devices. The flexible edition X-ray system introduced an innovative spot ROI function, which employs a square hole filter to reduce radiation while preserving imaging quality. There is a scary hole filter on the front part of the X-ray tube that permits full X-ray passage through the square hole region of interest, while the area surrounding it outside the region of interest undergoes a 65 85%, thus reducing via copper filter. Excessive culmination or reduced frame rate can degrade the imaging quality, but spot ROI provides clarity while selective reducing dose. In this way, the operator and the radiologist technologist perform the procedure while communicating with each other. As they become more experienced, and the technologists can adjust the spot ROI in real time according to advancement of the wire, or follow the pattern or stent with the spot ROI, even without a direct instruction from the operator. The assistant in the cath lab can also operate the spot ROI as needed during the procedure. Here I would like to demonstrate the effectiveness of the spot ROI function in reducing radiation exposure. This slide compares produced performed without spot ROI and with spot ROI. Spot ROI utilizes a dedicated filter with a lecturing hole, which creates both a normal exposure area and a filter attenuated area. The position of the region of interest, the normal exposure area, can be freely adjusted according to the operator's need. According to data provided, Canon medical systems using spot ROI can archive and experiment radiation dose reduction of 50 to 65% in the filter attenuated area compared to conventional exposure. These substances reduction highlights the volume of spot ROI in minimizing radiation and exposure during complex procedure. This case presentation key steps, and this is a key step of the current case report. Fluoroscopy was conducted experimentally using spot ROI from the start of guiding catheter engagement. The wire successfully delivers CTO lesion with spot ROI. Despite a fluoroscopy time of 71 minutes, the total radiation dose was kept 990 mg, remaining below 1 gray. A 76-year-old man patient presented with CCS grade 3 angina. He has a BMI 20.9 and had a blood pressure of 130 medical. Electrocardiography level 2 waves inverse in raise 2 and ABF, where echocardiogram showed ejection function of 56% and inferior wall hypokinesis. He had undergone PCI to RCA and decade earlier and had been on hemodialysis for 11 years. JCTO score 4 points, JCTO channel score 4 points. Cardiac CT and CAG confirmed ISO and CTO region in the RCA, measuring approximately 60 millimeter in length with a JCTO score of 4. The patient should undergo PCI or RCCTO. However, because the region is extremely long, the procedure was anticipated to be lengthy. In addition, it has been reported that lesion characteristics such as moderate to severe calcified tortuosity, ambitious proximal cap, distal cap bifurcation, longer CTO occlusion lengths, and blunt to non-blunt stump associated with increased patient AK dose. Hence, reduction in radiation exposure was imperative. We therefore plan to use the spotlight function to minimize radiation exposure during the procedure. We entered 8 French L0.75 short chip guide catheter via the right femoral artery for the antegrade approach and 7 French EBU 3.5 guide catheter via left femoral artery for the retrograde approach. We chose to start with the primary antegrade wiring. By employing the spotlight from the outset, we were able to engage both guide catheters within 6 minutes, leading to initial radiation dose to 9.38 milligray. During the antegrade attempt, the thin black wire with the corsal profile to pass through the heavily cultured region. We then switched to a guided X3 wire. The fluoroscopy time at this stage was 3.6 minutes with a radiation dose of 87.30 milligray, which particularly advances through the region. Using the anchor balloon technique with the Zenrai 2.0 10 mm balloon, we advanced the Corsa XS microcatheter pathway through the city region. After 5.7 minutes of fluoroscopy, the radiation dose to 57.90 milliliter. Subsequently, guide next 4 wire successfully crossed to the CTO exit. The fluoroscopy time at the stage was 39.3 minutes, with a radiation dose of 341.563 milligray. We then extended the wire for the ground slam with a wire and proceeded with the balloon direction. However, advancing the thin rise 1.04 mm balloon proved difficult. To overcome this, we employ the guide extension proximal locking method, GP lock technique using a guide plus 5 French guide extension and the Zenrai 2.5 10 mm balloon at the proximal RCS site. The fluoroscopy time was 53.0 minutes with a dose of 614.35 milligray. Following the measuring the 1.0 and 4 mm balloon successfully crossed the region, allowing us to perform plain all balloon angiography with a Zenrai 1.04 mm balloon, followed by Kizashi and 3.5 10 mm balloon. The fluoroscopy time at the stage was 53.0 minutes with a radiation dose of 614.35 milligray. After assessment with the anterior IVAS, we performed a follow-up using to agent 4.0 and 30 mm drug elastic balloons at the occlusion site. The total fluoroscopy time was 70.0 minutes, and the final radiation dose was 950.73 milligray. The entire procedure lasted 65 minutes, and with the final fluoroscopy time 71 minutes. Contrast medicine volume of 140 milliliter, and radiation dose 990 milligray. The patient was discharged the next day without complications. Conclusion: the spotlight function integrated into the Alphenix Evolve Edition XA system. significantly reduce the radiation dose during complex PCI procedures, including CTO cases, without compromising procedural effects. This innovation technology promised a safer and efficient intervention cardiology practices. Further evaluation of safety and efficacy, the March Center and prospective study in world. Potential pitfalls, the projection file on available plexus alpha mix every additional X-ray system and cannot be used as other X-ray equipment. Therefore, the cost of purchase this new X-ray system can be called issue. In addition, because the image quality outside the skull hole is lower compared to standard collimation, operators needed careful and frequently confirm the positioning of guide catheters and wire chip, among other details. Take-home message, by using the SPOT ROI function, it becomes possible to perform complex PCI with a remarkably low radiation exposure. Even in cases that may be lengthy or technically challenging, thereby greatly enhancing safety by reducing radiation-related complications. Furthermore, it may also provide useful for cases as CTOs that carry a risk of high radiation exposure, as well as for less complex procedures. Thank you for attention.